okay.
Yeah, I know. I'm too lazy to put my hand up.
So by the hands in the room, we can tell that it is something that doesn't happen a lot, but it is something that is life-threatening and we need to be aware of in the operating theater, as it is precipitated by us. Can anybody tell me what agents create malignant hyperthermia? Volatile gases. Anything else?
Some of the muscle relaxants
Succinylcholine
can do it.
The depolarizing neuromuscular agent. So in malignant hyperthermia, what happens in your muscle cells, you have the sarcoplastic reticulum, which carries our calcium, and there's a channel or a receptor in there called the ranitidine 1 receptor. And in malignant hyperthermia susceptible patients, that receptor has a mutation in it. So when we give the volatile gases or succinylcholine, that receptor then locks in the open position and calcium influxes into the muscles. So patients on the operating table, they can't tell us that things are feeling weird. Can anybody tell us where is she? Amin.
Mm-hmm.
What's the first thing that we normally notice?
Increase in ET.
End-tidal CO2 usually goes up first in patients experiencing malignant hyperthermia. And people that have had this MH crisis, has an anesthesiologist firmly said all of a sudden, I think they have an MH, or they like kind of swirling around at the top trying to
Flustered, yes.
figure things out,
figure
and
it
they're
out.
just like, what's going on? And they're like very
Sometimes
busy
they
up at
think
the
there's something
top.
wrong with their machine.
Yeah.
Yeah.
Yeah,
It's just
they
so-
stand up.
Oh yeah.
And they get very uncomfortable looking, and they're not, and that's one of your first cues as a nurse, being like, something is going on, and maybe I should open my eyes and ears to anesthesia, because as we know, they're behind the curtain and they kind of get forgotten up there lots of times. So when anesthesia has, oh my god, face, you might want to take a look at the monitor and see what that end-tidal CO2 is doing. Another thing they're going to do is start drawing blood gases to see if they do have that serum level of end-tidal or CO2 level rising as well, to see if they're acidotic. The other thing that you're going to start to see in lots of patients is they're going to start to get really rigid, and your surgeon is going to be like, is this patient relaxed? What's going on here? Have you given a relaxant for this patient? And yeah, the patient's
Our
relaxed.
patient was on the fracture table in traction. There was no way they would
so,
know.
And every MH susceptible patient, if they get that triggering agent, they may not have an MH event. So somebody who is MH susceptible may have a safe surgery, and the next time they have surgery, they may have an MH event. So it's not guaranteed, and there's no test intraoperatively as well to let us know that it is a conclusive event that is happening. So the best thing that you can possibly do when you see things happening, such as end-tidal CO2 rising, patients are going to get tachypnic. The anesthesiologist is going to try and compensate for that. So they're going to increase their respiratory rate and see if they can blow off more CO2. Often the CO2 is still rising. And they're going through their head, what else could it be? Could it be some sort of pneumoperitoneum contraindication? Could that be happening, increasing end-tidal CO2? Anyways, I digress. The best thing to do when they are doing that is you go and get the MH cart and just park it outside of the room, because dantrolene is the only antidote for malignant hyperthermia. So your first steps in the process is go get the cart. You're going to call for help, get as many hands on deck as possible. One nurse is going to start helping anesthesia by changing everything out. You need new water traps. You need these carbon filters if you are in a case, and you need to put these on to their inspiration, expiration. So on our monitor, inspiration will be on, when you're looking at left, expiration on the right. So they need to line up properly. You're gonna get a new CO2 sample line, filter, bag, and circuit.
Yeah. They're all on the cart, right?
Yeah, they're
On
all
top.
in the bottom
Yeah.
drawer.
Yeah.
So, you're going to put the filters on, you're gonna change everything out, and you're going to make sure anesthesia is ready with Tiva.
Can I back up?
Huh?
Can I back up
Yeah.
a bit? Anesthesia will immediately start a propofol infusion so
That's
that they
what I
can
was
switch from
saying, Tiva.
gases. Before we change the circuits or anything, we take the vaporizers off and remove them from the room. They have to sit on a flat surface, so you just put them on a cart
The
and get
Diva
them out.
modules, yeah.
And then you ask anesthesia if they can flush the machine. Just put their finger on the button and
That
flush
big-
the machine as you're changing.
That big O2 button.
Yeah.
And if you can, increase it to 10 liters so that you can get a real good flush on that system. You only need 90 seconds with the filters on to clear as much gas as possible to make it safe, and these filters will last for up to 12 hours intraoperatively. So if you're in a really long case, you can go for up to 12 hours using these before you have to change them out again. And yes, you make sure you pull out the Diva modules, and then you make sure anesthesia is ready with Tiva, so total IV anesthetic, and make sure they are ready for you to switch this out by bagging so that the patient is in stable condition before switching over everything. And then we are going to start mixing dantrolene. So, people who have been in MX crisis have clearly mixed it. The process has gotten a lot faster and easier. You just basically, you have to use these vented dispensing pins, sterile water with no bacteriostatic agent, so no preservative in it. This spike dispensing pin goes into the bag. You put on your 60 cc syringe, draw it up. These are special syringes, special order, so we're gonna play with just 50s so that we're not wasting our special order ones. You're gonna draw up your sterile water, bacteriostatic, with no bacteriostatic agent. And you're going to insert these vented pins into the medication. These vented pins take away the necessity of having to pull out air or force air in. So you basically are in, out. It's not a hard process like it is for normal medication updraws. And then you're going to just agitate the solution.
Gently, if you vigorously shake it, it frothers.
Yeah, so you just want to
Froths.
gently agitate it
Yeah.
and make sure it's clear.
An entire 60 ml syringe.
Yep. it
60
does.
ml syringe.
Yeah.
And then you draw it up, hand it to the anesthesiologist. For best practice, we should probably have labels put on there so that
Multiple people can be drawing at the same time.
Yeah.
yeah, we
I
need
was
people like
lucky-
it's a team effort.
I had Sean and Julian in recovery, and they had no patients there, and I just
It's an assembly line.
I spiked them and handed it to Julian. He did it, drew it up, and put them all in a kidney basin.
Yeah.
And he'd written on the kidney basin
Yeah.
dantrolene on there, so it was actually very smooth because we had the people to do it.
So, and that's exactly it. It's a very, very life-threatening emergency. 20-minute delay in dantrolene can increase detrimental effects by 30% to a patient. So we need to get on top of dantrolening our patients ASAP. We have this lovely conversion chart. It is in the policy. There was actually one that was on here from eons ago. And it had, so MHOUS Standards is Malignant Hyperthermia Association of the United States. It's a nonprofit organization that gives you resources and they have a 24-hour hotline that you can call if you are experiencing an MH crisis. So you can pick up that phone and call the hotline, which is on the binder, on all the posters, if you are needing help in an MH crisis and there are people a phone call away. Anyways, gold standard is 2.5 milligrams per kilogram of dantrolene for patients. So they say standard, MHOS standard is having
60 vials, I think it is.
36. I was like just doing the math. 36 vials, and that should be enough for a 70 kilogram patient for the initial crisis. You can dose up to 10 milligrams per kilogram if patients are not receptive to your initial loading. And patients can also rebound for up to 72 hours after their initial MH crisis. So you need to make sure you have enough dantrolene in the hospital if you've had an MH event. So you need to get on that horn and call pharmacy and see what we have for backup in-house if we've had an MH event, especially on an evening or weekend. And
You might get some pushback from because it's a pharmacy assistant that will come in, and they might say, oh, well, I'll deal with it in the morning. If we do not have dantrolene in the department, we cannot operate.
and we cannot.
Anesthesia will not anaesthetize patients because it's indefensible in a court of law to do that. So you might get a bit of pushback, and you'll have to push back again to them and say, no, you have to come in. They have increased the amount of dantrolene that we hold in the hospital now because we were chasing and getting stuff from Golden Fernie Trail.
Yeah, hot-shotting over the
Hot-shotting it in.
weekend for $500.
And our
so-
pharmacy assistant said, this is ridiculous, I'm going to get this changed.
Yeah.
And she did. She work really hard on it.
Okay, so conversion chart. It kind of gives you a basis of how many milliliters you need to administer reconstituted for the anesthesiologist if they need a quick look. And where I was going with this, the old resources had multiple different dosings at the top, and then their med math calculations were also incorrect. So goes to show you, again, trust no one and don't trust resources that are necessarily or read them.
I'm not sure we can do that.
No, but you have to read them. You have to look
Yeah.
at the actual information on it. You can't just blindly grab it and trust that that is a document that you need, because there was 4 different doses on there, and one of them
It was
was
bad.
correct.
I don't know where it came from. It was like
I don't know either.
completely incorrect.
Yeah,
Well,
and for
anesthesia get their phone out and they get onto the M-House website
yes,
as well. And
they do. But for
There's one dose, right? It's 2.5 milligrams per kilogram.
Yeah.
That's the dose.
that's the standard M-House dosing. So as we go through this MH crisis, you've dissolved all your dantrolene. Other things that are going to happen are in this part we have other things. Can people think of things that might happen in an MH crisis? So our muscles are spasming and we have lots of calcium. What can also possibly be happening in our body?
Cool them down.
We want to potentially cool them down. Temperature is often a later response, so sometimes you don't even have to cool them. But we do have cooling solutions in the fridge in PACU. But the other things that we are going to need are things like bicarb to protect the kidneys, because we are severely acidotic, and furosemide as well to get on top of helping flush those kidneys out and protect them as well. Another thing that happens is calcium. You get a lot of serum calcium from that ion exchange. So a lot of patients are susceptible to cardiac events. And that is another thing that might explain an MH event or an unexplained cardiac event in the operating room. Could be an MH actual event. And another thing that is not in this chart, but you might get asked to go for, is regulate insulin. And we will administer that in conjunction with dextrose solutions, so we can force that potassium back into the cells and also not bottom the patients out. Make sense? All right. The other thing is we want to insert a Foley catheter, because we want to monitor their urine output and monitor the color of the urine because they can get myoglobinuria. So all that muscle breakdown is getting filtered into the kidneys and
Can you look at your chair right there?
ejected
sorry,
out
they're trying to
into
handle it.
the bag.
That's fun when the patient's on the fracture table.
Yeah. Goal is 10 milliliters per hour with a MH case in acute phase. All right, does anybody have any questions?
So the PAR staff check that cart once a month, it's on their monthly checks. But if you've got any downtime, pull it out, go through the drawers, have a look and see what's in there.
That's
Because
what's here right
although
now.
PAR check it, we're the ones that are gonna have to be using it and know where stuff is, and it just makes it a little bit more efficient. So just pull it out, have a look. We might even have expired dantrolene that you can play with as well.
We do, and we're gonna do that after in just a couple seconds. The other